Hello, I'm Dr. Epling, and this is evidence-based medicine. And we're talking today about studies about therapy, things that you do to people as a doctor, counsel people, give to people in order to make them better. These are some of the most frequent studies you'll see, and we'll go through how to critically appraise them. So we'll start first with an introduction. Basically, what are therapy studies? They're any sort of intervention. They can be pharmaceutical interventions, surgical interventions, screening, counseling. Anything a doctor would do to somebody counts as being amenable to a therapy study. The study design for these, the best therapy study you can do is a randomized controlled trial. That gives the best opportunity for the two groups to be equal, except for the intervention that you're studying. And we'll get to how that matters in a little bit. But there are other study designs that you can use to see if an intervention works. You can use a cohort study, either a retrospective or prospective cohort study. These are observational studies. In other words, people are already taking the intervention for some other reason. You're comparing with a group that isn't taking an intervention. And you can do that both forwards and backwards, prospectively and retrospectively. You can use a case control where you look back at people, and this is a little bit different when we think about intervention studies, but you can look for people that have certain outcomes and you can look backward to see if they received a certain intervention. And then finally, you can do case series. These are important to begin to build the evidence cascade. They're often used in surgery if it's a particularly rare type of surgical intervention or a very rare case that they're doing surgery on. You'll sometimes see people try certain interventions and then report on them. That's a case series done in a number of different patients. So let's talk about the validity of these studies. What makes these studies really good? Therapy studies, the key to them is, and the key to all the validity components is to make sure that the two groups you're studying are as close to exactly the same as you can get them, except for the intervention that you're studying. Whether you're studying two groups or three groups, maybe an active intervention that you're studying, a control intervention, and maybe a placebo, all those groups need to be as similar as possible with respects to all the characteristics you can think of: gender, age, race, comorbidities, all these things that can impact a study's patients in a study, their characteristics. The four major points that I want you guys to know are allocation, concealment, randomization, blinding, and withdrawals and follow-ups. So these are the major validity points. Allocation concealment is perhaps the toughest for people to get. It's sort of a type of blinding, but it's blinding before people actually get into the study. So I don't want you to confuse it with the normal intervention blinding. Allocation concealment is during the process of recruitment for a study. A recruiter, say they're in studying in a waiting room and trying to recruit patients from a waiting room in a doctor's office. The recruiter has to go up and apply the inclusion and exclusion criteria for the study to any individual that seems eligible. They go through those inclusion and exclusion criteria, and then the recruiter gets them into the study. They sign the consent form, they do all the stuff that they need to do to get them into the study, and only then is the patient recruited to, or the subject recruited to the different, rather allocated to the different groups. What is the way this actually works? Well, you can imagine a recruiter that has more nefarious intent, say, coming up to a patient that looks very sick and not wanting to recruit them to the study because they know that the patient, say, is going to land in the intervention group. Well, that could very much bias the study. So we don't like to include, we don't like to let the recruiters, the people bringing the patients into the study, know the group to which the patients will be randomized. This is often done by using a off-site randomization center, usually by computer randomization or something like that. Randomization is the second point. Randomization is important, but it depends somewhat on sample size. You can randomize people to different groups, and if you don't have a big sample, you can often get very unweighted groups. But with more and more sample, when you randomly allocate them to an intervention, you're pretty sure that all of their characteristics can be equally divided between groups: age, gender, race, comorbidities, different habits like smoking or drinking, but also just things that you can't think about. And the bigger the sample and the better the randomization method, then you can be relatively sure that the groups will be equal in all the respects that you need them to be, except for the intervention that you're studying. Randomization is best done by computer randomization or maybe a random number table, but these are the important things to look at. Blinding. Blinding is mainly intervention blinding. That's what we're talking about. So you've heard of single-blinded and double-blinded studies. Double-blinded study means neither the patients know which group they're randomized to, but the people caring for them don't know which group they're randomized to. And this takes advantage of the placebo effect. What you're trying to do, again, in the interest of keeping the groups the same, is making sure that the patients, all the patients in the study, think that they have the same possibility of being on the treatment group. And this can be a little bit dodgy at times. There can be interventions that are hard to blind, like surgeries, like counseling. Those are very, very difficult to blind. If you're looking at complementary and alternative medicine, there's a lot of discussion about whether it's possible to blind those things. But to the extent that you can, you want to try to get blinding so that the patient doesn't know the group to which they were randomized. Finally, withdrawals and follow-up. Withdrawals and follow-up are important. You don't want to lose a lot of patients from a study. Why? Well, there are two reasons. One, it reduces the overall power of the study. We'll get to power in a little bit. But if you lose sample size from your study, in other words, if patients leave the study, then you might not be able to detect an intervention that's truly there. The second aspect is that if you lose patients at a different rate, in other words, one group loses more patients than the other group, then you begin to unbalance the randomization. And patients may be leaving for reasons that might be related to the outcome. And so you'd want to minimize the amount of withdrawal and follow-up. Basically, the researchers should know what happened to every patient in their study, especially if they're real big ticket outcomes like death or morbidity. The researchers should make an effort to find the outcome for every individual and at least understand what the major outcome is, even if they don't have the opportunity to do all the other testing that might be in a study. So those are the four major points: allocation, concealment, randomization, blinding, and withdrawals and follow-up. The secondary validity points, these are still important. Power is one. So every study should have a power analysis, and what that does for the study is it's a calculation depending on the level of significance you want to be able to see in a study. We usually say that we want significance at the 0.05 level. In other words, we're going to call something significant if the statistical test done on it has a p-value of less than 0.05. We call that statistically significant difference. So you actually set that in the power analysis. The second part is that you want to be able to see a certain amount of difference. Now, this can be a 10% difference in morbidity or mortality. This can be a 10-point drop in blood pressure. There are a number of different ways to talk about the difference you want to be able to see for the primary outcome. But that's part of what you're looking at with a power analysis. You put all those factors into a calculation and you get a sample size, the number of people you need to have in your study in order to see the difference you want to be able to see. So it's important that the researchers do a power analysis, and it's important that they ultimately get the number of patients they thought they needed based on that analysis. The second kind of minor statistic or minor validity point is baseline differences between the groups and adjustment for those differences. What you want to look at, randomization is a random process, so any differences you'd see between groups are there just by chance, but you want to make sure that they're not going to accidentally balance the study. Every time you flip a coin 10 times, you don't necessarily get 5 heads and 5 tails. Sometimes, just by chance, you can have differences in the group, and those differences might be important. So the researchers need to look at that, usually the table 1 in their studies, look at the baseline differences between the groups, and figure out if they're significant or not. Sometimes this is done by p-values. They do p-values between the two groups to tell if a certain characteristic is significantly different, but you don't need that. You can use the data from that table 1 and do what's called a regression analysis, either a logistic or linear regression analysis, or some other sort of statistical adjustment of the results to take into account the differences between the groups. And so if you look at a table 1 and you notice there's some differences between the groups in a factor that might influence the outcome, then you'd want to make sure that the researchers go back and adjust for that statistically. The final point is something called intention to treat analysis. Basically, this says that once patients are randomized to a certain group, the control group, the experimental group, whichever, they need to stay in that group for the analysis. And researchers will often claim foul. If it's a drug study, for instance, and the patient stopped taking the drug, then they say, well, if we don't switch the patient to the control group and analyze them as to whether they took the drug or not, we'll never know if the drug actually works or not. And that's true. There's a per protocol analysis and an intention to treat analysis. The per protocol is if patients stick to the protocol. In other words, if they end up taking the drug they're supposed to take or get the surgery they're supposed to get, you compare them to those that didn't get the surgery and exclude all the rest of them. But that again gets to, if we exclude patients from groups for different reasons, then we might be biasing the study. So the way to compensate for that is this intention to treat study. Everybody gets analyzed in the groups to which they were randomized, and even regardless of whether they actually took the intervention or not, took the drug they were supposed to take, got the surgery they were supposed to get, or whatever. As long as you present both the intention to treat analysis and the per protocol analysis, as long as the researchers do that, that's considered a reasonable exploration of the data. Ultimately, you can't be sure if something works unless you do an intention to treat analysis, because there may be something that's so awful about the drug or so difficult to take about surgery or counseling or whatever, that the intervention may not be actually just practical in the real world. So that's what the intention to treat analysis can give you. So next up, we'll talk about the results and how to look at the results of a therapy study. So there are several different ways that we look at results in therapy studies. The first way is descriptive, just to be able to describe who got in the study and generally what happened to them, maybe how long the people took the medicines, both the placebo and the intervention. You're just describing what happened in the study. And often the first place you look for this is in Table 1. This describes who actually got into the study as a result of randomization. And so Table 1 looks over the different characteristics of the patients, how many patients in each group, how many patients within each individual characteristic. And there can be a number of different tables that look at these sort of things. You'll see both continuous and categorical data. Continuous data being means and medians and their corresponding error intervals, the standard deviation for mean and the interquartile range for the median. And you'll just see comparisons between the groups and whether or not those comparisons are significant sometimes, the authors are also look at. And then you'll see categorical data, how many in each group were smokers, for instance, or how many had diabetes. You'll see comparisons between those. And that's useful to know who actually got into the study. And then you get into the comparative results, and these are the critical results that everybody wants to see. They're sometimes called the inferential results. Basically, we will have a whole different presentation on looking at the results specifically, but you're looking for, in continuous data, you're looking for comparisons of means. So you'd see a mean difference between the groups at the end. And this could be like a mean difference in blood pressure or a mean difference in cholesterol or something like that. And you can take that to mean that as the result of the intervention, their cholesterol went down, their blood pressure came down, whatever the value is. The number of days it took until they got better, for instance. If it's a smaller number in the intervention group, then you know that intervention worked well. And then you'll see the comparative results for categorical data. These are the relative risks, relative risk reduction, absolute risk difference, and number needed to treat. Remember, the relative statistics just tell you the outcome relative to the control group. And these can sometimes be misleading because they can give, for fairly small differences, they can be pretty dramatic relative risks. So in other words, if there's a 1% risk of the bad outcome in the control group and you reduce that to 0.5% risk in the intervention group, that's still a relative risk of half that the patients will actually have the outcome. But it may not be that big a magnitude. If your overall risk is 1% over a certain time and you reduce it to 0.5% over time, you're not really changing that individual's risk. And that's why absolute risk reduction or absolute risk difference, either reduction or increase, is so important when we talk about results. Because not only does it give us the idea of whether or not something is reduced, it gives us the magnitude that they benefit from. So if I'm at 50% risk for a disease over my lifetime, and you can reduce that to a 10% chance over my lifetime, That's pretty significant, and that gives you an absolute risk difference of 40%. The number needed to treat for that is about 2.5. You invert that absolute risk reduction. So you would only have to treat 2.5 people like me to make a difference, and that's a magnitude that's pretty impressive. Whereas with the previous study, the previous statistic I quoted you, from 1% risk over 10 years to 0.5% risk, that's a 0.5% change. So you need almost 500 people before you showed a difference between those with that intervention. So you need to really kind of think about what you're doing with your statistics, and have an emphasis for and a preference for absolute risk differences and numbers needed to treat. And then authors will often do regression and multivariable analysis. First of all, they'll do it to adjust for those baseline differences that we talked about earlier. They're always looking for different confounders and associations, so they're used to explore not only the data they have in front of you, but to generate other hypotheses for future study. So it may be that an intervention works well and you see a significant result, but you may have noticed that you had certain populations in there that you think might be doing better, and so that sort of information would come out with a regression analysis, and then set up the next study that can be used to look at that further. You'll see logistic and linear regression. The differences between those is in the outcome variable. Logistic regression is used for a dichotomous outcome variable like death, or achievement of a certain say blood pressure level. If you get your blood pressure down below 140, then you can say yes, we got it down, or no, we didn't. And that takes a continuous variable and makes it a dichotomous variable. Linear regression would be where the outcome is a change in blood pressure. So for every 1-point change in blood pressure, these other things are associated with it. And you can do linear regression on more continuous outcomes. Other statistics you'll see are ANOVAs and the other multivariable analysis techniques to look into a study's data more.
Okay, now a couple of examples of data presentation. The first one we have is forest plots. Forest plots are used in both therapy articles and systematic reviews to kind of drill down into the data a little bit. Here you see two outcomes, myocardial infarction and stroke. And here's where, in therapy articles particularly, they separate out according to subgroups. In this case, the subgroup is a different type of non-steroidal anti-inflammatory. And they look at the statistics associated with that particular subgroup. So in this case, it's a rate ratio, also known as a relative risk. And you see credibility intervals, which are basically confidence intervals. And so you see the point estimate associated with naproxen's effect on myocardial infarction here with the square. And then you see the whiskers out on either side, which are associated with the confidence intervals. And you can go down this center line here is the line of no effect. In other words, for relative risk and odds ratios, that's the line of no effect is 1. And so anything that crosses 1 is not significant. And down here we have one significant one for refacoxib, a relative risk or rate ratio of 2.12, and a confidence interval that excludes 1, so we know that's significant. You come down here further, and there's one more down here, lumiracoxib, down in the very bottom here, has just a barely significant rate ratio here. So it's a way to subgroup out what's going on in the study and see it clearly for each of the individual subgroups. We'll see a different example with systematic reviews.
This is a Kaplan-Meier curve. This comes out of, it also deals in hazard ratios. This comes out of a Cox proportional hazard modeling, which is a way of, or survival analysis modeling, which is a way of looking at the results from a study if it's done over a long period of time. You have different people coming into the study at different times and having different times of exposure to the intervention. So you would sort all those out by doing that proportional hazards modeling statistic, which is something that you hire a statistician for. You get hazard ratios at each time, and what this shows, if you look at the cursor, is time over weeks, the progression-free survival probability. So this is without any progression, 100% of the people have not had progression at time 0, all the way down to at 40 weeks out, about 60% of people are with 65% of people are without regression in this arm, and only 35% are without progression in this arm. So you can compare two interventions that way, how they work over time. Sometimes you can see two interventions doing well in a short time, and then the curves begin to separate. One of the important things here is to look for this p-value. This p-value talks about the differences between these two lines. Just because you see white space in these two lines doesn't mean that the difference is significant. You have to have that p-value, that idea that the two things are in fact different statistically. The other thing you have down here, remember we talked about the people could be in the study for variable amounts of time. And once you've had an event, you're no longer eligible for the event in a study. In other words, if the study were studying heart attacks and you have a heart attack, that's one of the primary outcomes of the study, then the study stops following you to see if you have continued heart attacks. You've already met that criteria. So any further study should kind of exclude you from the analysis because you've already had the outcome. And so that's what this down at the bottom is doing. The number of people that are eligible for the outcome are the whole study initially, and then over time, as people get the outcomes, there are fewer and fewer people as part of the analysis, and that's what that Kaplan-Meier curve demonstrates. Okay, on to applicability. Therapy studies, applicability is a key component, and this is often where the biggest fights are in figuring out whether there's evidence should be used or not from research. Does this evidence really apply to my patient? That's kind of the central question. Other terms for applicability, the things we're talking about, generalizability is another term for it, and external validity is another term. It's all the same thing that we're talking about, though. And remember that internal validity is important because that makes sure the study is done well, and that means that the study is applicable or is true. The study results are true for that population, that little sample studied. But what we really want to get from these studies is generalizable knowledge. In other words, how likely is it that the study's results would apply to the rest of the population? And that's what applicability looks like. So is the study useful for others, and to whom can the study apply are the central questions. So some applicability criteria: is the intervention available? It seems like a no-brainer, but you got to think about that. Just because a certain intervention is shown to be better doesn't necessarily mean that you have it available to use on your patients. And available can mean a bunch of different things. It's either not paid for by insurance, it's too costly to afford, it's not available in your area, you don't have the skills or technique to apply the intervention, all sorts of ways to think about intervention availability. Does the population studied match the population I care for? So you have to go back to the inclusion and exclusion criteria and the research question, if you will, and look at it and say, are they studying the same patients I want to apply this evidence to? And this can be a little bit tricky. The next question gets to this too: are the intervention and comparison both reasonable? So not only do you have to look at the patients and who they are, and do they have the same diseases and comorbidities and other characteristics that my patient does, but are the intervention and the comparison the right ones? One of the favorite tricks of some drug company manufacturers is to take an active drug, the drug they want to prove works, and compare it to a lower than usual dose of a comparator drug, an ineffective comparator in this case. That you have to really keep an eye on and look and make sure, if you're comparing starting doses, that the starting dose from the comparator drug is truly the starting dose recommended by their company, for instance, versus the starting drug for the intervention. So really look at the patients, make sure they're the same sort of patients that you would apply this study to, and make sure the interventions and the comparators make this a fair study. And then finally, does the study examine patient-oriented outcomes? Patient-oriented outcomes are things that patients would care about: morbidity, mortality, quality of life outcomes, cost, hospitalization rates, ability to functional scales, ability to get up and walk around and do the things that patients need to do, activities of daily living, these type of things. Stuff that you could say to a patient, yeah, I'm fairly sure my patient would feel like this is an important outcome. A lot of stuff that we study in medicine doesn't have these patient-oriented outcomes. They're disease-oriented outcomes. They're measures of things that the patients frankly can't feel, like cholesterol levels and maybe a little bit of blood pressure level and those type of things. We know they're probably important, but what this to drop cholesterol levels and drop blood pressure levels, for instance. But it doesn't capture the big picture. There may be costs to reducing blood pressure levels, and if you don't study those costs in terms of overall mortality or associated morbidity or any of those things, then all you know is it reduces the blood pressure. You don't know what else the intervention does to the patient. That's important to know. So patient-oriented outcomes are the final applicability criteria. Okay, we're done with therapy studies. Read up the information on the wiki, look at the other resources if you still have questions, and have a good day.